Hello, and welcome to Precision Athletic Training Home Study CEUs. I am Megan Hunt, the Vice President of Precision Athletic Training, and I'm happy to have you logged on today. Precision Athletic Training provides quality and convenient athletic training services for sporting events. We were founded in 2009 and began providing CPR and CEU opportunities for athletic trainers in 2013. Please note that the course evaluation form and assessment form are posted on the same page as this video. Please remember to download them, fill them out, and email them to me at mhunt@precisionat.com. When I receive these, I can then email you your statement of credit for the course. If you have any questions, please email me or call me at 781-366-1880 during normal business hours. Our presenter for the Concussion series is Cassandra Johns. Cassie earned her undergraduate athletic training degree at Florida Southern College and her master's in science at Georgia Southern University, focusing on concussion research. Her thesis was focused on the prediction of concussion utilizing baseline assessment tools, which she presented on at NATA in St. Louis in 2015. Along with this, she's also the second author of The Role of a Certified Athletic Trainer/Therapist in Concussion Management, which is published in Current Research Concussion, a Canadian research journal. Without further ado, Cassandra Johns.
Hello, and thank you for joining us for the first part of our four-part concussion series. In this section, we'll be talking about epidemiology of concussion. If you have any questions, my email is on the screen. It's cassie@precisionat.com. So you can just email me after watching this, and I will do my best to answer any of the questions that you have. So without further ado, let's get started. So I wanted to start off this presentation kind of going over the domains of athletic training. And I know that as athletic trainers, we know what our job entails. We're really great at the clinical evaluation and diagnosis. We're great at the immediate emergency care aspects of things. We know how to treat and rehabilitate injuries, and we get the organizational and professional health and well-being aspect of things. But what seems to be most overlooked and why it's highlighted in red is the injury and illness prevention and wellness protection aspect of this. There's definitely research as far as ankle injuries, knee injuries, shoulder injuries, and the prevention and protection of those. But there's not a lot of research in that as far as concussion goes. We're definitely going to go into stuff that's been done towards the end of this presentation, but it's hard to prevent an injury if we don't know how to yet. And sometimes it's hard to focus on that aspect anyway due to time management, the number of athletes you're seeing versus the amount of hours that you have to see them. All of those things kind of play in. And they're definitely pieces of that puzzle that go through it. So while you're watching this presentation and while we're going through things, I really want you to think about the injury prevention aspect and the wellness protection aspect of this. Part of that can fall into the education aspect and how can we protect our athletes if they don't really know what the injury is. How can we protect our athletes if their parents are pressuring them to play, because you'll see that sometimes when the parent doesn't understand what a concussion is. I know I worked with a coach when I was newly certified who thought, you get hit in the head with a baseball, you're going to get a concussion, which is true, but he didn't think it was a concussion. He was like, oh, well, it's normal. You get a headache, you're dizzy, you're lightheaded, it goes away in a couple days and you're fine. And we had to sit down and have a nice long talk about how, yeah, that of course it's going to happen when you get hit in the head with a baseball, but that happens because your brain's injured and you have a concussion. So those are just kind of things to focus on. I don't believe that coaches are trying to put their athletes in danger by any means, but I definitely think there's still an educational gap. I mean, not that long ago, we were letting athletes return same day. So when you have a coach that's been coaching for a while, or you have a parent who played sports themselves, you're going to kind of have the educational gap because they know what it was like when they were doing it, so why is it so different now? So that's definitely part of the protection aspect. And think about things that we can do to prevent kind of while you're watching this and things that you might be able to implement into your practice. And our next slide, we're going to get into some of the mechanisms, so we'll have some fun videos to watch. So we're going to start off with just a couple of videos that go through the mechanisms of concussions. Most of the videos that you'll see are direct blows because that's what people tend to put on YouTube, but as we'll get through later, a lot of concussions occur without a direct blow to the head. So this is the OSU California game, I believe 2 years ago. And you see the OSU player on the ground. I think he's OSU. The California player on the ground, excuse me. Going through, and you'll see it again in slow motion, where he lands kind of on his shoulder, hits his head, and the helmet falls off. And then he has that temporary upper body paralysis that is kind of a trademark symptom of some sort of head injury, whether it be concussion or something else. So that's definitely something that if you see, you want to take further action on. And we have this lacrosse hit. It's a head-to-head hit, so kind of pay attention. It's going to replay. So you see it happening here in slow motion. This player collides into him, and it's a head-to-head hit. Sorry about that. We'll watch it one more time. I know it's not the clearest of videos because they tried to slow it down so much, but you do get to see the hit right there pretty well. You watch both players very slowly fall to the ground in this video. Then I have two gymnastics videos for you, mostly because we don't tend to associate gymnastics or swimming or some of the non-contact sports with concussions, so I wanted to include two videos that kind of show that you can get a concussion in any sport, as we know. So you're watching the athlete doing the flip right there. She kind of falls on her back and then hits her head on the ground after the fall. And then the last video is this one right here. You're going to watch her land on her head right after her tuck. So that's a pretty telltale one. We're going to kind of expect an athlete that has a mechanism like that to have a potential concussion. So to get back into it, basic definitions of a concussion would include that it's a brain injury with a complex pathophysiological process that affects the brain and is induced by biomechanical forces, and it also alters the way that the brain functions. So these are each pieces that we're taking out of the 4 CIS, and where I know that you guys can read them, I just want to go over them because they are important parts. So a concussion may be caused by either a direct blow to the head, face, neck, or elsewhere on the body with an impulse and force transmitted to the head. Concussions typically result in rapid onset of short-lived impairment of neurological function that resolves relatively spontaneously. But in some cases, signs and symptoms may evolve over a number of minutes to hours. A concussion may result in neuropathological changes, but the acute clinical symptoms largely reflect a functional disturbance rather than a structural injury, and as such, no abnormality is seen on standard structural neuroimaging studies. And lastly, concussions result in a graded set of clinical symptoms that may or may not involve loss of consciousness. Resolution of the clinical and cognitive symptoms typically follow a sequential course. However, it is important to note that in some cases, symptoms may be prolonged And again, all of these are from the 4th International Consensus Statement on Concussions. So common presentation. Excuse me, I might pause a few times to get a drink so I don't lose my voice throughout this, so just bear with me. So we know that there's about 22 symptoms that are associated with this, and we should have a graded symptom checklist either on our phones or in our kits in case one of our athletes sustains a concussion. This simple checklist could include headache or having an athlete feel pressure in their head, temporary loss of consciousness, which we should be able to recognize, but sometimes it's so quick and there's other things going on the field that you might not see that. Confusion or feeling as if they're in a fog, amnesia surrounding the traumatic event, dizziness or seeing stars, ringing in the ears, nausea and or vomiting, slurred speech, delayed response to questions, appearing dazed or fatigued. It's important to know your athletes when this is going on because some of your athletes may already be a little spacey, but if you don't know them and they seem spacey, definitely err on the side of caution with the presentation of concussion symptoms. So you might see slightly different things in children. They're going to appear to be dazed, and they could be tiring easily. They are likely going to be irritable and or cranky. They're going to have loss of balance and some unsteady walking, which again you could see in your collegiate athletes as well. They might be crying excessively, whether it's due to the depressive state that the concussion puts the brain in or because they don't really know what's going on. And they could have a change in eating or sleeping patterns, which is something you're going to want to talk to their parents about because those might not be things that you're going to see. And another thing you could want to talk to their parents about is they could have a lack of interest in their favorite toys. So where their parents might not approach you about this being an issue, they'll be forthcoming if you ask about it. So definitely follow up with the parents following the concussion or suspected concussion. So when a concussion occurs, a neurometabolic cascade of mild traumatic brain injury occurs. So what happens through this is there is an influx in sodium and potassium with the sodium and potassium pump, which increases the sodium, or the potassium, excuse me. And you're also going to see the influx of calcium and the ATP to keep up with the influx of calcium, which could ultimately lead to cell death. You're also going to see a decreased cellular metabolism with that influx of potassium and altered neurotransmission. With this, you're going to see a delayed response to further injury, and it might not even be an adequate response to further injury, which is why you really want to keep on athletes that may have a potential concussion because you don't want the neurometabolic cascade to go wrong. And this also is going to put the brain into a depressive state, partially because of the altered neurotransmission that's occurring and the ionic flux within the brain. It just creates a pretty intense chemical imbalance as a response to the injury itself. So with concussions, 1.6 to 3.8 concussions occur annually, which could be an inaccurate number for a couple of reasons. The last study that was done on this was in 2006, and because 50 to 60 or 70% of concussions go unreported. The 60 to 70% is relatively new research. I read it right before doing this presentation, so it's not in here, but the 50% was found in 2003. Your mechanism of injury could be a direct blow to the head. However, many concussions occur without a direct blow, so it's occurring with rotational or accelerational forces. There's some conflicting data on these forces, but your mean, where the rate is likely inaccurate, your mean linear force in high school is said to be 93.6 Gs, and in college, 102.8 Gs. Your mean rotational force in high school is 6,402.6 rads per second squared, and in college it's a little bit less than that. It's 5,331.6 rads per second squared. Now, with this, these are forces that you're potentially seeing in car accidents. So these are pretty intense forces that you're seeing on the field. Most of this data was done with football players, but you're going to get the rotational and accelerational forces in almost any sport to some degree. And this just shows the head's going to be up right here. It's going to be hit from one side here and hit down here. So it's just to kind of show you some of the mechanisms of injury that could be occurring. So this is a pie chart of an epidemiology study. It is only one study, so just kind of bear with me with that. I have another one later in the presentation, but you're going to see slightly different numbers, but I really want you to focus on the trend that you're going to see with this one and the one later on in the presentation. Football is going to account for the most concussions across the board with athletics. However, what's important in here is the rate of women's concussions in soccer versus men's concussions in soccer, and the rate in women's basketball versus men's basketball. Even with baseball and softball, usually there's more concussions in the female counter sport. You can kind of see that here. So the point of this being, when male and females are playing the same sports, the females are going to be more likely to suffer a concussion, which we're going to see a little bit later as well. So what about the preventative aspects of concussions? What about mouth guards? Currently, there's no evidence to suggest that mouth guards actually prevent against concussion. Their primary purpose is to prevent against dental injuries. So this is going to kind of show you the concept of why they're saying that mouth guards might be preventing a concussion. They're saying that if you're wearing the mouth guard, this is a particular mouth guard ad, so it's just the mouth guard in general that we're concerned about here. But if you're wearing a mouth guard and you get hit in the head, it's supposed to help absorb the shock, especially if you get hit from the jaw, and therefore decreasing your aspect of a brain injury. However, when you're looking at this, how many concussions are you getting where you're getting a direct blow from the chin and going up, and how much force is that really going to absorb? The mouth guard is more likely to prevent the dental injuries that are going to occur from that than anything else. So it's kind of a false fact right now that mouth guards prevent concussions because there's a lack of evidence with that. So what about other aspects of prevention? So with helmets, the primary purpose of a helmet is to prevent a brain bleed and or a skull fracture. Helmets actually do little, if anything, to prevent the actual concussion, since most occur without direct blows, and the helmet can't stop that from happening. This is just kind of show you how helmets have evolved, and this is the helmet now. You're going to see a huge decrease in rates of skull fracture and brain bleeds in football. You're going to see a big decrease in catastrophic injuries in any sport that has a helmet because of what the helmet does. But you're still going to see concussions in those sports, and a pretty large number of concussions at that. So what could actually be preventing the injury? Well, rule changes could prevent it. You're probably going to see in a couple of years women's lacrosse and field hockey having to wear helmets to help prevent brain injury. You're more likely to see the helmet preventing concussions in those sports because of the way that they're getting hit and because they're not a real true contact sport. So with that being said, I would keep an eye on that. You're probably also going to see football rule changes where kids aren't tackling as early as they are now. You see those rule changes in hockey where kids can intentionally hit, I believe it's till age 12 or 13. And you're going to probably see rule changes in soccer where they're not being taught heading until the neck is stronger and able to absorb some of that shock. You hear the argument about risk compensation within injury prevention. This is more so towards the athletes that are playing football or hockey. You see a lot more football talk in the media, but when you're at the collegiate level or the professional level, you're likely getting compensated to some degree for what you're doing, whereas in high school and youth, you're not. So the thought process behind that is you're not old enough to understand the risk and the compensation that you could be receiving from it. Another thing you're going to look at is aggression versus violence. A lot of contact sports are aggressive sports, and as athletic trainers, we know that. That's the culture of athletics. But hitting with aggression versus hitting with violence are going to be two different forms of hitting, and you're probably going to be at a greater risk of injury if you're hitting or getting hit from violence versus the aggression that naturally comes with the sport. Education is a huge part of injury prevention. You're not going to prevent the concussion from happening with education, but you're going to be able to hopefully teach people how important it is to report the concussion to you. And when that happens, you're able to prevent the subsequent concussions from happening before the first one heals. So you're preventing second impact syndrome, which we'll get into a little bit later more of what that is. And by educating the parents and the coaches, hopefully you're going to have a little bit less backlash when you actually diagnose somebody with a concussion and more of a support system. And these are the sources from that. So also within prediction, you have a dose response mechanism, which puts you at a 3 to 5 times greater risk of sustaining a concussion after the first concussion has occurred. So it's a range because you're at a higher risk after each concussion. So say you're at a 3 times greater risk after your first concussion. By your third concussion, you're probably at a 5 times greater risk. And those are just numbers to be thrown out there on how that risk actually escalates. Some research does say it's a 3 to 8 times greater risk, but most of what I've read and most of what I've worked with is in the 3 to 5 times greater risk category. So SIS is second impact syndrome, and as we know, it's a pretty rare condition, but it's also extraordinarily fatal. 50% or more cases of second impact syndrome, result in death, and most of the ones that don't, I mean, there are kids who have second impact syndrome that turn out fine. Most of the kids who have second impact syndrome and don't have a catastrophic outcome have a pretty big change in their quality of life and could need lifelong care afterwards. So second impact syndrome is definitely something that we want to avoid, but you can't always prevent it if you don't know the concussion occurred. You kind of have to rely on your athletes being honest with you throughout the diagnosis process, and you also have to rely that they're being honest with you throughout the return to play process. So you're also looking at long-term deficits within prediction, and that's more so predicting whether these are potentially going to occur. So if you're in that miserable minority of athletes that have a concussion, so the ones that don't resolve within 7 to 10 days, they're going to be at an increased risk of long-term deficits because their brain's been at a injured state for so much longer than your average concussion. Also, the more concussions that you've had, the higher your risk is for having any long-term deficits associated with a concussion. We're not going to go into all the long-term deficits in this lecture. We're actually going to have a separate lecture. It's the 4th part of this series. So if you want to learn more about that, tune into that study as well. So with prediction, we're also looking at gender. And there's a few different aspects of gender that could put females at a greater risk. One of them is neck strength. It's thought that when a male is getting hit, they brace their body. So they have the neck strength, they have the core strength. Their whole body braces for that impact. Where females tend to close their eyes and look away, and then they don't have anything to help absorb the shock of the impact. Another aspect that is talked about in the literature, but it is pretty controversial, is that females might just be more forthcoming. They might be more honest when it comes to their injury. And what that means is mostly probably a cultural issue versus anything else. Males are taught at a young age that if they're not bleeding or it's not broken, that they need to kind of suck it up and go. And you're seeing that change a little bit in these sports now, but females aren't taught that. They're kind of coddled a little bit more, so they might just be more willing to come forth with the injury because they're not going to be pressured as much from the coaches or the parents or their teammates for being out because they're hurt. Concussions are tough for kids because they're the invisible injury. They're also tough for collegiate athletes and really any athletes in general, where people can't see what's wrong with you. And in this day, we've heard a lot about concussions. We know a lot more about concussions than we did 8 years ago. 10 years ago, I know when I was in college, it was just hitting the point where they couldn't return to play same day. And that really wasn't that long ago, so it's factoring in the changes that we've seen over the past decade and the education that we've seen, where people are becoming a little bit more honest when it comes to reporting, but you still have a lot of kids that think that playing the sport is more important than telling you about their concussion, or they just don't know what's going on and it is a lack of education. So kind of with that debate. Basic genetics, some people are more likely to sustain a concussion just because of their basic genetics, and your mechanics are going to impact it. If you have proper mechanics with your tackling or hitting or whatever you're doing, whether it's gymnastics and you're doing layups and doing bars, or I know I water skied, when you don't have the proper mechanics of doing something, you're more likely to fall, which puts you at a greater risk of injury, and that's where that comes in. So what else are we looking at with prediction within sports? So there's the head and pat telemetry system, which is the HIT system. I don't know how much you guys have heard about that. So they have accelerometers inside of the helmets that measure the rotational and linear forces and the impact that's happening from the hit. And you actually see it on a screen. So especially if you're one of the only athletic trainers at a big football practice, if you have somebody looking at that screen, you know what kids to pull to evaluate for a potential concussion. It gives you a little bit more control because you have the red flag hits, but just because an athlete didn't get red flagged on the hit system, it doesn't mean that they don't have a concussion. You also have the female versus male sports, which we kind of discussed earlier. We're going to discuss a little bit more now. So you have football, which has the highest rate in here, I believe. Yeah, so you have football, actually, it's not the highest rate. So you have football with the 6% of all injuries, but then you have women's ice hockey, which is actually the highest with 18.3%, which is more than double what the men's ice hockey risk was. And you're going to see that every sport on here has some degree of concussive injuries per 1,000 athletic exposures. And this was done to a 95% confident interval. So the researchers are 95% confident that this data is correct. You're going to see more concussions here in softball than baseball, in women's basketball versus men's basketball, and in women's lacrosse versus men's lacrosse, where it's a small number, like a small difference, it definitely is a difference. And then you're going to see almost double in women's soccer as you saw in men's soccer. So that mimics the chart from earlier, where you see more concussions in the female versus male population of each sport. So there's been a decent amount of focus on lower extremity injury in relation to concussion. It's been found that athletes are at a 1.56 to 3.79 times greater risk for lower extremity injury following concussion. And this is important just because we're going to kind of go into this in a couple of slides, so I wanted to preview it first. So we'll get back to it in a few minutes. So prediction with medical history, or prediction kind of in general. Your female athletes are going to be at a greater risk, kind of as we discussed. Your pediatric population is also going to be at a greater risk. So anybody whose brain hasn't fully developed, or anybody under 18, because your brain really hasn't fully developed when you've gotten to college yet either, is going to be at a greater risk of concussion than their adult counterparts. Any learning or behavioral disorders, so you're looking at ADHD, ADD, depression, anxiety, or personality disorders are going to put you at a slightly greater risk of sustaining a concussion as well. And again, that medical history that we talked about, so that dose response mechanism, the number of concussions you've had in the past, or if you've had a medical condition that might increase your risk. There's been some talk that migraines, or somebody who has a history of migraines, might be at a slightly greater risk of concussion than somebody who doesn't get them already. So what about prediction with prolonged recovery? Excuse me. So a positive post-traumatic amnesia, or PTA, symptom at the time of injury is going to potentially put you at a greater risk of a prolonged recovery. So a greater risk of taking that time period that's longer than 7 to 10 days. For a long time, loss of consciousness was thought to be, or LOC was thought to be, one of the greatest predictors of a prolonged recovery. However, we've kind of figured out in the last decade that it might not be. Loss of consciousness could be your body's way of protecting your brain when that does occur, so that might not necessarily put somebody in that miserable minority prolonged recovery group. Your total symptom score. So somebody who's reporting a lot of symptoms and severe symptoms is going to be at a much greater risk of that prolonged recovery group than somebody who has a total symptom score of like 7 or 8. Because that person's obviously not experiencing pretty intense symptoms at the time, but they could worsen, and they could be they could worsen, or they could be in that prolonged recovery group before their return to play. And that migraine symptom cluster. So I'm not sure how many of you have experienced migraines in the past, but your migraine symptom cluster is going to be exactly what it sounds like. So blurred vision, seeing stars, light sensitivity, noise sensitivity, nausea, vomiting, severe headache, dizziness, anything along those lines. And vomiting is one of those symptoms that if your athlete's experiencing it, you're probably going to refer them to the emergency room to rule out a brain bleed pretty quick. So let's go back into that prediction of injury. So you have a study that was done by Swanek in 2007 at University of Delaware that looked at ACL prediction utilizing all 4 composites of impact, and he found significant correlations between all 4 of those composites. Now, his reaction time correlation cutoff in relation to the study we're about to talk about next was 0.57, so it was very close to Wilkerson's study, which was performed in 2012. He's at University of Chattanooga, or University of Tennessee at Chattanooga, I apologize, where he looked at lower extremity sprains and strains utilizing the reaction time composite of impact, and he found that a reaction time of 0.56 or higher put an athlete at a greater risk of sustaining a concussion. And then we're going to go back into the stat that I gave you a couple slides ago that put an athlete at a 1.56 to 3.79 times greater risk for a lower extremity injury following a concussion and your history of concussion, which we've kind of highlighted throughout this whole presentation as a predictor of concussion. So now we're going to get into kind of what I did for my thesis and the purpose of that, and just kind of highlight some of our major findings as far as prediction of concussion went. The purpose of our study was to examine the components of the pre-participation examination as potential predictors of future concussion risk. We found that the multifaceted assessment and lower extremity injury history were not significant for predicting concussions in this particular study. So to highlight one of the biggest limitations of our study before we kind of go into it, these are our demographics of what athletes were participating. Our experimental criteria meant that they had to sustain a concussion at the university during their athletic career. So that could have happened on day 1 or their very last day, but they had to have sustained a concussion during that athletic career. One of our biggest issues was matching those athletes with athletes that hit their matching criteria. So we matched based off of the year they got the concussion, if we could. If they got it as a freshman, we tried to match them with another freshman. If they sustained the concussion as a senior, we tried to match it with another senior. We also matched based off of their concussion history prior to coming to us. And when we could, we matched off of lower extremity injury history, but that ended up not being a good match factor for us, so that was eliminated pretty early in. So as you can see, we had 36 football players in our experimental and only 20 in our control. And the 8 baseball players you see in our control helped us hit our mark on how we had to match football. So matching outside of sport definitely skewed our results. We matched swimmers with cheerleaders, partially because we had no more cheerleaders to match with. And we matched women's soccer with softball when we had to. So, and one of the women's tennis players. So when we kind of looked at this and we looked at matching volleyball, tennis, softball with women's soccer, that was one of our greatest limitations throughout, which is why I firmly believe the study should be redone with a better matching criteria with people who may have more time to complete the study. So I'm going to show you my ROC curve, which is a pretty complicated statistical analysis. So I wanted to show you a sample one. This is from Wilkerson's study that we just touched upon. What should happen when you're looking at significance in an ROC curve is you'll have these little raises where they're coming back to the dotted reference line, but then you have like this mountain looking line that comes back down, evens out, and then comes back down again. So that's where you're going to hit approaching significance within the ROC curve. Mine's a little bit more overwhelming than that, which is why I'm supplying you with that reference sheet. So this is our ROC curve, and to kind of reference you or get you kind of acclimated to it, this is the black reference line. So we have this going on as our reference line. This is reaction time, which started to approach significance in the opposite direction of what we would have wanted it to. So this is actually showing the faster you had a reaction time, the less likely or the more likely you were to sustain a concussion, which we know likely isn't true. But that's what this particular study was showing. It was very concerning for us. We were kind of happy that it didn't hit significance because that's a hard thing to explain. And then this is a processing speed, which also started to approach significance, but that was in the direction that we would have hoped. And the last one that started to approach but did not hit significance was Bess and verbal memory. When we ran just the lower extremity injury, which is not, it's represented on here, but it does not start to hit significance on here, we found that when we were able to hit all the people who had lower extremity injury data, it started to approach significance with knee injury, not quite so much with ankle injury. But we had athletes who didn't complete their participation examination questionnaire form, so we ran into a few issues with that as far as whether or not it was going to approach significance or not. So why am I telling you this? Why is this important? Concussion research has begun exploring prediction and prevention mechanisms, and this study begins to rule out the multifaceted baseline assessment as a predictor. And I say it begins to rule it out because the study might not be representative of all the athletes out there, and redone, you could find significant results. That's why we tend to repeat studies multiple times. If a clinical predictor of concussions were to be found, then a clinical prevention guide could be developed, which would decrease the amount of time that we're spending rehabbing concussions or treating concussions. Where sometimes it's hard to fit the time in to prevent injuries, it would be a huge mile marker in our profession in the medical field if we could start preventing concussions. So that's kind of why this research is so important. Cervical strength is one of the only known prevention mechanisms, and motor control. So those are things that we can control and we can start to get better, but it takes a long time for those things to change. So that's not our best prevention mechanism as of right now. And I don't know how many of you really test cervical strength every single time you see an athlete. I know that wasn't part of our baseline assessment, so it's another thing you might not know, that they are at an increased risk with the cervical strength until they actually sustain a concussion and you start looking further into it. So what was the conclusion of this study? The study showed that there were no differences on any of the components of the pre-participation examination between experimental and control groups. There were also no clinically significant predictors of concussions within the pre-participation examination. However, when we matched sport to sport, we started to see some promise and some significant results, but we didn't have the size of a population to include those in our publication. But we found with women's soccer that a decreased reaction time and a decreased verbal memory score, a decreased verbal memory score were possible predictors. And we found with men's soccer that processing speed and visual memory were potential predictors. So it would be interesting if somebody went to do this study later, did it sport by sport versus the way that we did it. And future research should explore prediction and prevention mechanisms, or should continue to explore that. So in summary, gender differences are going to be big predictors of concussions. So you're going to be looking at cervical and core strength, which we've kind of honed in on here. You're going to be looking at mechanics, and you're going to be looking at genetics when it comes to gender differences. And you're also going to be looking at the fact that females could potentially just be more forthcoming with their symptoms, but that is a pretty controversial aspect. So you definitely don't want to accuse any athletes of not being honest with you when it comes to reporting their symptoms. You really have to have that trust relationship with your athletes that they're telling you the truth on what's going on. Lower extremity injury could potentially be a big predictor with more research. And it's something where if you have an athlete that gets a concussion and they have a history of ankle sprains or knee injury or whatever the lower extremity injury may be, you could factor some of that rehab in while they're returning to play to try to decrease that risk, or that increased risk of having another lower extremity injury. Having a history of lower extremity injury, we know that they're already at a greater risk. And then on top of the concussion, we definitely don't want to increase their risk more than they have to. And then the neurometabolic cascade, which I just kind of want to recap on because I know it's kind of a confusing aspect. The sodium-potassium pump in the brain starts working over time, which increases the amount of potassium that's found in the brain. This in turn also increases the amount of calcium in the brain, which domino effects to an increase in ATP in the brain, which could all potentially lead to cell death. This also decreases the cellular metabolism with the influx of potassium and creates altered neurotransmission. So your neurotransmission could either be slower, or it could be skipping a step, and it could just not be doing what you want it to be doing. This is also going to have an altered response to further injury, which is why it's so important to recognize the concussion the first time so you don't have your athletes going into a greater risk of post-concussion syndrome or a greater risk of second impact syndrome. If we can identify it and treat it initially, the neurometabolic cascade is going to go a little bit more smoothly, and it's just going to make our life a lot easier. And this also puts the brain in a depressive state, which is really important when you're looking at behavioral disorders and mental health disorders that already exist with certain athletes. And it's kind of just important in general, even if they don't have those. That depressive state can be what leads to the suicides following concussions. And where we don't know the exact reason why an athlete would do something like that following a concussion, we do know that the neurometabolic cascade plays a part in it, and that the depressive state and the depression that follows a concussion definitely plays a part in it. So they start to lose interest in things that they would normally enjoy, and they feel like when they're not playing sports that they're kind of losing a purpose in life, especially with those athletes who have played their whole life and all of a sudden are out for weeks, they're going to be at an increased risk, and they're not going to really understand or like what's going on with them. So you kind of factor all of that together. It's a recipe for disaster. So it's something that we want to keep in mind when we're training our athletes, that this could be happening, and keep an extra eye out for those depressive symptoms or signs that could be leading to something like that. So at this point, I know it's a home study. We don't have time for questions because this isn't live, but you are welcome to email me if you have any questions. Again, my email address is cassie@precisionat.com, and it's Cassie with a K. You can also put any questions you have in the course evaluation form that Megan's sending you for her to be able to give you your statement of credit, and at that point she'll be able to forward any of those to me. I hope you guys have a great rest of your night or day whenever you're watching this, and please let us know if you have any questions at all.